Okay, so that's the last thing that we have finished. We kind of actually, I realized that we kind of talked about it actually, like the formation of penis and all of this stuff. We sort of discussed it last class. So you remember that we have a couple of swellings here. These swellings are on the outer covering of the cloaca. So that's where the ectoderm will be. We have the genital swellings here, the genital tubercle and cloacal membrane. They consist of the mesenchyme. And you remember that neuronuclear cells do not participate here, like they're not common to this area. So you remember that here we'll have the perineal body, which is the tip of the urorectal septum. And because of the urorectal septum, because of this tip, the cloacal folds will be divided into two, into the urethral folds and into the anal folds. The urethral folds will become the labia minora in a female, because in a female, genital tubercle is not elongating. But in a male, genital tubercle is elongating because there is abundance of DHT, right? So dihydrotestosterone is present pretty much everywhere. So that causes your genital tubercle to elongate dramatically. Okay, so if genital tubercle is elongating, it changes its name. Now it is called phallus. Phallus is elongated genital tubercle. Phallus starts its proper elongation around week 9, 10. So closer to the week 10. That's when it is elongating a lot. Because actually during the 6th week, it is impossible to distinguish the cells, the sexes. So from 3rd until 6th week, this is when the indifferent stage is present. So you have something like that. Like it's impossible to know, is it a male or is it a female? But closer to the week 10, this is when the genital tubercle is elongating a lot, right? So that's when we have the phallus. But this is also very confusing because in some girls, genital tubercle is also a bit longer than the rest of the tissue, so it looks like a penis. So it's very, very difficult to actually tell the sex of the baby for sure, you know? So you need to wait a bit longer. So in the after the 5th month, that's when it is definitely the most proper way to actually say that is it a boy or is it a girl. If the phallus is elongating, you're going to see that the two urethral folds are approaching one another, right? So they're coming in closer together, because you can imagine that if this structure is pulling upwards, the two urethral folds are going to come close together. But very interesting is that when the two urethral folds are coming close together, the inner part, the lumen, stays open. So it doesn't fuse entirely everywhere. This lumen stays open. Why? Because the area between the two urethral folds possesses proliferated ectoderm. This proliferated ectoderm keeps the lumen open. It's like, imagine you put something thick in this area. So even if you try to pull the two things together, this thick part in the center will not allow you to fully collapse the structure, right? So this thick brick in this area, this is the stratified ectoderm. So it is actively proliferating there, and this stratified ectoderm will be the future penile urethra. So it definitely has nothing to do with the transitional epithelium. It's just going to be some kind of stratified epithelium in that area. When the two urethral folds fuse, the two scrotal swellings will start to go downwards. It's like, imagine that you had one scrotal swelling here, one here, but then something causes them to descend a bit downwards, and not only to descend downwards, to also fuse together in one area as well. So there is a line of fusion of the two scrotal swellings. As you know, it's called the scrotal septum or median raphe. We have two median raphes, one in the mouth and one on the scrotum as well. So that's why it's quite funny. But yeah, it's also called median raphe. It's like the line where the two scrotal swellings are fusing. What causes these two scrotal swellings to go downwards a bit? because these two scrotal swellings, exactly starting from like 13th week, testes start to be there. Okay, testes start to fill this area. They will be a bit heavy, so they will be kind of dropping these scrotal swellings, and these two scrotal swellings will fuse together as a result. So the answer to why the two scrotal swellings fuse, because they contain testes. Okay, we have talked about it. In the female, nothing changes, right? So this picture is exactly like it is in the female, no changes whatsoever. So the only thing that changes are the names. So urethral folds, labia minora, genital swellings, labia majora, genital tubercle, clitoris. This is quite important in the anatomy as well, because we have to understand how exactly do testes descend, right? So how come they end up in the scrotum? As you know, originally, testes are located on the urogenital ridge. Do you remember this from the last class? What participates in making urogenital ridge? What is present there? So gonads and mesonephros. Okay, so gonads together with mesonephros, they are going to be making up a structure which is called urogenital ridge. So testes are located in that urogenital ridge. On the surface of that urogenital ridge, we have urogenital mesentery. So this blue area, everything which is in blue covering, this is called urogenital mesentery. There is a part of the urogenital mesentery which possesses extracellular matrix, a bit too much of it. So it is a bit thick. And this part of the urogenital mesentery, which has this extracellular matrix, has a name. It is called gubernaculum. So you can think about gubernaculum as this cord within the mesentery that possesses too much of extracellular matrix. To kind of rephrase it, imagine that the rest of the mesentery is loose connective tissue. This part, specifically where gubernaculum is a dense, irregular connective tissue. So it is very dense. It has lots and lots of collagen fibers in that particular area. Gubernaculum at first is attaching to the testis on one side, and on another side, it is attaching to the pubic symphysis. But due to because don't forget, intestines are going to be here as well, chilling right there. So these intestines push the attachment of gubernaculum towards scrotal swelling. So imagine that pubic symphysis is in the center. Right on the two sides of the pubic symphysis, there are two scrotal swellings. So two gubernaculi were at first attached to the pubic symphysis, to the center. But because of the growth of the intestines, it caused these two gubernaculi to kind of move a bit. And the part to where they move, this is the scrotal swellings. What happens next? What is happening on the B picture? As you can see on the B picture, the testes are starting to move. So they were on the posterior body wall, but now they're on anterior body wall. They end up somehow here. Why is that? The most important thing to understand about descent of the testes, that this is a super slow process. How slow? Testes will reach the inguinal region by the 12th week. They will migrate through the inguinal canal by the 28th week, and finally be in the scrotum by the 33rd week. Do you see how slow this process is? It's not like this. It's not like today, I don't know, we start the process, tomorrow the testes are in the scrotum. What does it mean that this is a slow process? It means that the reason why the testes descend into the scrotum because of the growth of the embryo. Embryo will be growing very slowly, but gubernaculum's length stays the same. It doesn't stretch. It stays exactly the way it is. Let's imagine this is my anterior body wall. This is my posterior body wall. Gubernaculum was initially like that. It was attaching my testis to the pubic symphysis, right? So super tiny gubernaculum, 12-week. Your embryos throughout the entire 9 months enlarges like 1000%. It becomes super big. The body cavity expands. What happens to gubernaculum? It stays the same. If it stays the same, if the anterior body wall expands, that means that gubernaculum is being pulled by the pubic symphysis to this area. If gubernaculum is pulling, that means that it is pulling on the testis. So testes start to descend. Descent of the testis is not an active process. It happens because the body is expanding, but gubernaculum is the same size. So do you get it? It's like I keep you under, like, I don't know, it's like a chain, okay? It's like, I don't know, you're walking with a dog, you keep the same distance. But if you increase the distance between the dog and you, but the chain is the same, the dog comes close to you. Do you get it? Like it's still going to be approaching close to you. So the same idea is here. The reason why testes are actually descending, because the body cavity is expanding while gubernaculum's length stays the same. So it ends up pulling the testis right next to it. When the testes end up near the inguinal canal, or better said, when they're within the inguinal canal, you can see that a bit of the peritoneum ends up there as well. Why is that? Because this peritoneum was on the anterior surface of the testis. If testes come close to this area, they basically push through the entire peritoneum, right? If it is on my anterior surface and I keep moving, a bit of peritoneum will always be with me. But very important is that once the testes start to descend through the inguinal canal to the scrotal swellings, the connection with the rest of the peritoneum, so like this part, should degenerate. Because if it doesn't degenerate, we end up with something which is called hydrocele. Hydrocele means that a bit of the peritoneum is still present in the scrotum. As you know, within the peritoneum, we have fluid. Due to gravity, what is this fluid going to do? It's going to go to the scrotum. So how will the scrotum look like? It will be huge. It will be huge sac. So this is the number one symptom that you see, like a sign that you see if babies are born with a very, very big scrotal sac, definitely they have hydrocele. Hydrocele, I repeat, it means that it's not only this, there are two types of hydrocele. This is also hydrocele. It's just that this is continuous hydrocele. This is discontinuous hydrocele, but it's not important to know the differences between them. Hydrocele basically means that there is still connection to the peritoneum. There is still this canal between the tunica vaginalis, which you remember is the peritoneal layer of the testis, and the rest of the peritoneum. This part should have degenerated while you were still in the inguinal canal. It should have degenerated while you still were in the inguinal canal. If it doesn't, definitely fluid will go through this and start to accumulate here. So because you're passing through the inguinal canal, in the inguinal canal, we have layers of the abdominal wall. In histo, we have talked about it, right? So a part of the abdominal wall will be present in the scrotum as well. So like external spermatic, right? Fascia, cremasteric, and internal spermatic fascia. So each layer of the abdominal wall will give rise to something in the scrotum, except for what?
Transversalis fascia.
Not fascia, the muscle. Okay, so transversalis muscle will have like a opening in the inguinal canal. So when the testes pass through that opening, they get nothing from the transversalis muscle, right? So they're not gonna get anything from there. I will send you a video of a process, how it happens, how the testes descend downwards. But the basic idea that you have to understand that it is a very slow process. It is slow because the embryo grows slowly. If the embryo grows slowly, gubernaculum is not stretching. It's not. It stays the same length. If it stays the same length, it pulls the testis to the scrotum. Most important thing, gubernaculum was at first attached to the pubic symphysis, but it reattached to the scrotal swellings. So in a way, scrotal swellings pull the testes to themselves, right? Because gubernaculum is attached to the scrotal swellings. Why are they pulling it? You add more vertebrae, you're growing, you're slowly expanding. So of course they will pull the testes. Okay, here we're talking about descent of the ovaries. Technically, it also happens. It's just it's not very active process. Okay, so basically the descent of the ovaries, it means that, I don't know, your gubernaculum is also attaching to the scrotal swelling. So in females, it's also attaching to the scrotal swelling, the gubernaculum. But in females, scrotal swellings are not coming close together. There's no descending of anything like that. So the only thing which we should ask ourselves, what happens to the gubernaculum in the female, right? So what does it actually become in the female? It becomes the ovarian ligament and the round ligament of uterus. So these two ligaments, they are the parts of the gubernaculum in the female. Scrotal swellings in the female do not fuse because in the female, we do not have AMH, anti-Mullerian hormone. Anti-Mullerian hormone is very important for not only inhibiting Mullerian duct in a male. Anti-Mullerian hormone is also the regulator of the descent of the testis. So simultaneously as it inhibits Mullerian duct from becoming uterus and fallopian tubes, simultaneously it causes the two scrotal swellings to come close together. The whole descent of the testis is regulated by the anti-Mullerian hormone as well. So in a way, if they ask you why ovaries do not descend in the female, because we don't have anti-Mullerian hormone. Okay, so we don't, estrogen does not allow you to have it. Ectopic pregnancy, embryo 1. Okay, so you remember ectopic pregnancy is basically pregnancy outside of the uterus. The three most common places are ovary, fallopian tube, and pouch of Douglas. Oh shit. Guys, sorry, I have to go answer it. I'll be back, yeah? Oof, they brought water. Sorry about that. Okay, so ectopic pregnancy, this is going to be the pregnancy outside of the uterus. The three most common places are ovary, fallopian tube, and pouch of Douglas. Out of these three, the most common place is the fallopian tube. Why? Because within the fallopian tube, we have cilia. The cilia should be swiping the zygote or oocyte towards the uterus, but they don't. Fun fact, most common reason is pelvic inflammatory disease due to chlamydia. So chlamydia leads to that. Tobacco, if you smoke, that will also lead to that. And just general history of infertility. So if in your family it's very difficult to get pregnant, then that will also lead to that. Okay, there's some additional information there, so just read it, but they typically don't ask about that. Okay, so what should we do next? What is the next thing? Let's do placenta. That's actually also a bit of a review of histo. Majority of those things we talked about it in histo. So placenta, is it maternal or is it fetal organ?
Maternal.
It's a trick question. There's a secret option C. Secret option C that it's both, right? So secret option C that is actually going to be both. So it's not only maternal, it's also fetal as well. So you remember how the early phases of the placenta were, right? So we had syncytio, cytotrophoblast, and somatopleuric mesoderm. They were becoming the villi. We had primary, secondary, tertiary villi. What's the difference? What's in the primary villus?
Just syncytio, trophoblast.
And cyto. So just two layers, syncytio and cyto. In the secondary,
The mesoderm.
somatopleuric mesoderm joins the party, and in the tertiary,
Blood vessel.
Out of this mesoderm, we create the blood vessel. Between the tertiary villi, we have intervillus spaces. How do you call them at first? These intervillus spaces, what is their name at first?
Lacuna.
Yes, trophoblastic lacuna. You remember within the syncytio trophoblast, we had a couple of cavities like spaces. We call them intervillus spaces. Spiral arteries open up into these intervillus spaces. In the tertiary villi, at the later stages, you remember that we have some kind of protrusions. We call them free or floating villi. The anchoring villus kind of anchors the tertiary villus to the rest of the pregnant endometrium, which we call decidua, as you remember. And then this part will be the stem villus. These membranes should also be for you familiar. There are three maternal membranes and two fetal membranes. The three maternal membranes are deciduo basalis, deciduo capsularis, and deciduo parietalis. As you remember, deciduo parietalis has nothing to do with embryo. It's that part of the uterus that at first has nothing to do with embryo. Deciduo capsularis is on the top of the embryo, because you remember that embryo implants itself into the endometrium. So it will always be covered by a little bit of the endometrium. So we call it capsularis. And basalis is the maternal side of the placenta, right? So this is the maternal side of the placenta. Now, in our uni, there is this part that we call, how do we call it? Like where the three of them meet.
Marginalis.
Marginalis, very good. Okay, so between three of them, like a common area, you'll call it marginalis. The fetal membranes are called chorion. Chorion technically consists of three layers at first. So that's syncytio, cyto, somatopleuric mesoderm. So these three layers, they give you something which is called chorionic plate. At first, this chorionic plate will have villi everywhere on all sides. But then, as you remember, bushy, right? So there's only the bushy part of the chorion stays here. This is the chorion frondosum. So only The tertiary villi stay only there where you have spiral arteries, and you have them where the deciduobasalis is. So only that part of the chorion will still possess tertiary villi if it faces the deciduobasalis, if it faces the spiral arteries. So that chorion is called chorion frondosum. The chorion which is facing deciduocapsularis will become smooth, right? You will call it chorion leve. Why does it become smooth? Because deciduocapsularis does not have spiral arteries, doesn't have them. So it doesn't give you this input of the blood. Chorion frondosum is the fetal part of the placenta. And you remember that placenta, 2 layers, maternal, deciduobasalis, and fetal, chorion frondosum. I repeat, in the chorion frondosum, we have tertiary villi. Okay, you remember how do we call these little units?
Cotyledon.
You're gonna call them cotyledon. How many cotyledons should there be?
8 to 12.
So something like that. Okay, so on average, it's actually quite a lot of them. It's about 20 of them. What is in the center of cotyledon? What is in its center? Tertiary villus. Placenta is all of it. This entire thingy, this is the placenta. So this is in the center of cotyledon, you will find tertiary villus, right? With the anchoring part, with the free floating, with lots of them there, and the stem. What is cotyledon bordered by? It's bordered by decidual septa. So if this is my deciduum right here, it will create the decidual septa right here. Decidual septa goes down into the intervillus space and divides it into 2. Do you remember this? So one intervillus space is divided into 2. Why? Because on one side of it, we'll have arterial blood. On another side of this septa, we'll have the venous blood. So here, there is venous blood here. It's like embryo brings waste, drops them here, but gets the good things on the other side. So this is your cotyledon. So each intervillus space, right? So there's going to be another tertiary villus right here. So this is used to be one intervillus space, but you divide it into 2, thanks to the decidual septa. So this is cotyledon. In the center of the cotyledon, tertiary villus, but it is bordered by the decidual septa. Yeah? There's some additional information. It's quite important to know. So the numbers, so it is approximately 25 centimeters in diameter, 3 centimeters thick, and approximately half a kilogram its weight. There is something which is called afterbirth. So the first couple of contractions are delivering baby. Once the baby is delivered, you have to deliver placenta. So there is the second afterbirth. So technically there are 2 births, births of the baby and birth of the placenta. It's very important that the entire placenta is being delivered, all of it. In 4th year, when you will watch the deliveries, you will see that doctor has to check the placenta. You open it up, you make sure that it doesn't have any bleeding, because if it bleeds, that means that it has bled in mom, right? On the maternal side, the uterus is bleeding. So that can create a clot, and the clot could kill the mother. So you react very fast. So you always check the placenta even more than you check the baby, because as you deliver the babies, you pick the baby, you gave it to the neonatologist. That's it. You don't deal with the baby whatsoever, but you spend some time with the placenta. You look at it. It's quite interesting, actually. Okay, there's something called velomentous insertion. What does it mean? If this is the placenta, you can see that umbilical cord is always in the center for it, right? Always umbilical cord from the fetal side is on the center. Velomentous insertion means that it's not in the center. It means it's somewhere here or here, like in the periphery. This umbilical cord is not in the center, it is in the periphery. Okay, circulation of the placenta, we have kind of talked about it. So placenta receives its blood supply from the spiral arteries. typically you will see approximately 80 to 100 spiral arteries. Within the intravillous spaces, you will see approximately 150 milliliters of blood. Okay, so you will see like total amount of blood within the intravillous spaces is 150 milliliters. Okay, you remember the placental membrane? The placental membrane is basically the placental blood barrier. Do you remember it? Placental blood barrier. So first syncytial trophoblast, then cytotrophoblast, then basement membrane of the cytotrophoblast, then connective tissue or mesenchyme, then basement membrane of a blood vessel, then endothelial cells of blood vessels. This blood vessel is fetal because you're going deep into this way, right? So that's the placental membrane. Okay, here are just some functions of the placenta. Just read it. It's blah, blah, blah. The most important things are hormones. Which hormones placenta makes? Progesterone, of course, from 3rd month. That's when it's responsible for making pretty much all of it. Estrogen, HCG. Fun fact, fun question, fun fact. HCG, do you remember its job?
To keep the corpus luteum
alive, so corpus luteum can keep making progesterone, right? And you know that HCG that's what you detect when you pee on the stick. So pregnancy test in your urine, you look for the HCG. HCG, is it high throughout the entire pregnancy? Every single month it is high, or is it high at certain months?
Only the beginning.
Very good. It's only high in the beginning. So the highest concentration of HCG is in the beginning, because then placenta makes progesterone. So what's the purpose of HCG? No purpose. So there's fun thing to do. 9 months old pregnant ladies do a pregnancy test and it shows that they're not pregnant because they do not have HCG. Okay, so it shows that they are not pregnant. So it's a really fun thing to do. But yeah, there's also placental lactogen, so human somatomammatropin. This is something which prepares mammary gland for arrival of the baby. So this particular hormone, which is made by the placenta, prepares mom's production of milk. So placenta will do that. Last thing, we have here the umbilical cord and circulation. Okay. So basically, the umbilical cord, we kind of know everything about it. You will read everything that I'm talking about here. Okay, so that's the first part. You go to the picture directly. So this embryo is approximately 5 weeks old. You can see that this is going to be the frontonasal prominence right here, right? So this is the optic placode. This is the otic placode. That's the ear right here. This is the
pharyngeal gut tube.
Very good. Pharyngeal gut tube, which consists of pharyngeal arches. This?
The heart.
The heart. Heart should be pushed into the thoracic cavity and it should descend a bit downwards as well. You can see that this is the chorionic cavity. This is the amniotic cavity. Amniotic cavity is lined by the amnioblasts. These amnioblasts, as you remember, come from the epiblast and they secrete amniotic fluid. Here you can see something which we call connecting stalk. Maybe you remember from embryo 1. Connecting stalk arises approximately on day 14. And what does connecting stalk consist of? What can you find inside of it? You can find 2 mesoderms, the extraembryonic somato and extraembryonic splanchnopleuric mesoderm. In embryo 1, you had a picture like this. So this was the amniotic cavity. Here you had the epiblast, hypoblast, yolk sac. From here you had connecting stalk. Connecting stalk was attaching to the chorionic plate, which consisted of the somatopleuric mesoderm, like this, right? then cytotrophoblast, like this, and then the in situ trophoblast, like this. On the top of the yolk sac, you had splanchnopleuric mesoderm, the extraembryonic splanchnopleuric mesoderm. On the top of the amniotic cavity, you have the extraembryonic somatopleuric mesoderm. So this structure here is the connecting stalk. Connecting stalk, as you can see, is the area where you see both somato and splanchnopleuric mesoderm. It's the area where two of them will proliferate. Connecting stalk is the future umbilical cord. So this is still 5th week of development, right? So embryo is still very young. So this is still connecting stalk. Now, the older the embryo gets, the more amniotic cavity expands. Eventually, you will see that amniotic cavity will fully expand into the chorionic cavity. So eventually there will not be chorionic cavity. It will all be occupied by the amniotic. So it fully expands everywhere. As the amniotic cavity expands, you see that it starts to line on the surface of the umbilical cord. Do you see? It starts to cover it. So what is the most outer layer of the umbilical cord layer? The most outer layer will be amnion. So at the later stages, you will see that amniotic epithelium will reflect onto the surface of the umbilical cord. Here you see something which is called primitive umbilical ring. It's in the middle region of the embryo. Primitive umbilical ring simply consists of ectoderm because that's the most outer layer. So this is like an opening that embryo has. This opening will be ectodermal opening. Very important to know what can you find inside of the umbilical cord when. So you can see that, for example, I see vitelline duct. That means that I could see the yolk sac maybe at the later stages as well. So which week is this? If I see vitelline duct, so probably from day, let's not do day, let's do weeks. So maybe like from week 3 all the way to the week 6. Okay, so from 3rd to 6th week, that's when you can see the vitelline duct inside of the umbilical cord together with the yolk sac. As you remember, the yolk sac disappears, so vitelline duct should also disappear. So at the certain time, you will not find vitelline duct and the yolk sac in the umbilical cord. They will be replaced by the intestinal loop. Remember, primary intestinal loop develops within the umbilical cord. From when to when? You remember? It's from 6th until 10th week. How did we call that process when primary intestinal loop is in the umbilical cord?
Hernia.
Don't forget physiological. Okay, so physiological herniation. Okay, so this is the normal process for development of your intestines. So from 6th to 10th week inside of the umbilical cord, you can find the primary intestinal loop as well. Of course, inside of the umbilical cord, you see vessels, you see 2 arteries and 1 vein, right? 2 umbilical arteries and 1 umbilical vein. But technically, if you see umbilical cord with your eyes, what will it have? Will it have 2 arteries and 1 umbilical vein? It would have something else.
1 vein and 1 artery.
So which kind of blood is in the umbilical vein?
Oxygenated.
So arterial. Which kind of blood is in the umbilical arteries?
Not oxygenated.
Venous. So yes, we say that inside of the umbilical cord, you see 1 umbilical vein and 2 umbilical arteries. Yeah, but when you look at it, you see 2 vessels, 2 umbilical arteries, which don't look like arteries. They look like veins because they carry deoxygenated blood. And then you see 1 umbilical vein that doesn't look like vein. It looks like
Artery.
Artery because it carries arterial blood. So that's why the confusion comes in. So definitely from the theoretical perspective, you have one umbilical vein and two umbilical arteries, but don't forget they carry the opposite blood. So when you're a doctor, when you deliver a child, when you look at the umbilical cord, you don't see one vein, two arteries. When you look at it, you see two veins, one artery. That's what you see. Okay, amniotic fluid numbers are important. It's important how much of the amniotic fluid is present when. So 30 millimeters at 10 weeks, about half a liter at 20, and about 1 liter at delivery, right? So 37 week to 40 week, you have approximately 1 liter of amniotic fluid. What is the purpose of amniotic fluid? Blah, blah, blah. Whatever you can come up with, it probably does it. Very important to remember that amniotic fluid is being drunk by the embryo. Embryo drinks approximately 400 milliliters of amniotic fluid a day. I always say that more than some students drink water in this uni. Okay, so some students fully rely on Red Bull and Coke. That's it. Okay, so that's all they drink. But yeah, embryo drinks approximately 400 milliliters a day. This is why drinking of the amniotic fluid is very important, because it establishes normal functioning of the kidneys, because these kidneys will be filtrating whatever you're drinking, they'll be filtrating your blood, so urine will be produced. But don't forget that urine is mostly water, because placenta is the place where you drop all of the toxins, where you drop all of the waste. We have something called umbilical cord abnormalities. So normal umbilical cord should be approximately 1 to 2 centimeters in diameter and 60 centimeters long. If it is shorter than that, it's not good. If it is longer than that, it's also not good. If it is shorter than that, embryo cannot move. If it is longer than that, it will wrap around certain structures of the embryo, which is also not good. Sometimes you see that umbilical cord has only one vessels, like one artery, one vein. That's also quite common, 1 in 200 newborns, so it's nothing to be alarmed. There's something called amniotic bands. Amniotic bands are simply amniotic epithelium, which is peeling off. So if I go back, you remember this is my amniotic cavity. Here I'm supposed to have amnioblasts. Sometimes these amnioblasts peel off. So they create these epithelial bands, which are just floating within the amniotic epithelium, amniotic cavity. These amniotic epithelial bands can wrap around some kind of structures and cause amputation. So in this baby, do you see that's the area where amniotic band has kind of wrapped around? You can see that the heel is black, it is necrotic. So what do we need to do? We need to amputate it. So this part has to be amputated. This is dead tissue. So poor baby's leg will be amputated. So this amniotic band are quite dangerous. So nobody knows why exactly they appear, okay, but they definitely do appear. So they just peel off. So the peeling off itself is not dangerous. It's that it can wrap around certain things, and that will be dangerous. You could have a little too much of amniotic fluid, which we call polyhydramnions, or a bit too little, which you call oligohydramnions. So as you know, when you're born, approximately 1 liter, that's the amount of amniotic fluid that is there. If you have too much of it, take a look, up to 2 liters of amniotic fluid, that's not good. Why is it not good? Because it can cause premature rupture of the membranes, PROM. It will cause premature delivery. Can you imagine this 2 liters amniotic fluid is pressing onto the membranes, right? Onto the amniotic epithelium or something like this. It can definitely rupture and you will be forced to deliver. Oligohydramnions means you have too little of the amniotic fluid, typically less than 400 milliliters. Embryo drinks 400 milliliters a day. So what's going to happen? If embryo doesn't drink, kidneys will be malformed. As you know, embryo breathes inside of the amniotic cavity. Approximately from 7th week, that's when you can already notice the breathing motion of the embryo. Nobody knows why. Nobody knows why exactly this happens, but definitely embryo starts to breathe from 7th week. Not breathe, but like have the motion of breathing, you know? But when the embryo breathes, what does he breathes in?
The amniotic fluid.
Amniotic fluid. And this amniotic fluid helps the formation of lungs. So this breathing motion, this incoming amniotic fluid definitely helps the formation of lungs. So if you have too little of the amniotic fluid, you will see that baby will be born with underdeveloped kidneys and underdeveloped lungs. Okay, so circulation. Let's talk about it. So here we have placenta. So this is before you're born because I have placenta. Okay, so this is before. Which kind of vessel is coming back from the placenta? Which kind of vessel? Umbilical vein is coming back from the placenta. So umbilical vein is carrying arterial blood. It's called umbilical vein, but it is carrying arterial blood. You remember that umbilical vein bypasses the liver, right? At first it was opening up into the liver, but now it bypasses it and attaches to the right hepatocardiac channel, which will become inferior vena cava. In embryo, we call it right hepatocardiac channel, but eventually it became inferior vena cava. How do we call a vessel which allows us to bypass? We call it ductus venosus, right? So ductus venosus. From the inferior vena cava, blood enters into the right atrium, and majority of the blood from the right atrium through the foramen ovale opens up into the left atrium. Remember, we're trying to bypass the lungs. That's not, we don't need it, right? So foramen ovale helps us. We bypass the lungs through the foramen ovale. Now the blood is in the left atrium. From the left atrium, it's going to go to the left ventricle. From the left ventricle into the aorta, will go to the rest of the tissues, whatever it needs to go, like brain. From the aorta, it will go down to the descending aorta or left dorsal aorta, umbilical arteries, we return to the placenta. If we had a little bit of blood going in, right? So for example, from here, a bit of blood went to the right ventricle. From the right ventricle, it will go to the pulmonary artery. But even there, we have a second option to bypass the lungs, which we call the ductus arteriosum. So even if blood ends up being in the right ventricle, still it doesn't go to the pulmonary circulation. It's going to go to the aorta through the ductus arteriosum. There are Roman numbers here, and these Roman numbers indicate the points of mixing of the blood. That's the area where blood can mix. So arterial will mix with the venous blood. The first place where mixing occurs is the liver itself, the ductus venosus itself, because the hepatic sinusoids, the portal vein, will be opening up here as well. So already at the level of the ductus venosus, the blood here is not 100% oxygenated. The second place where the blood can mix is the inferior vena cava, because the rest of the inferior vena cava collects blood from the lower limbs, right? So from the region below. So it's also not arterial. So that's the second place where it can mix. Third place where it mixes is superior vena cava comes in here, carrying venous blood from the cephalic region. So it's going to be mixing with the arterial blood here as well. Fourth place is the left atrium where we're mixing because a bit of blood is returning from the lungs. So there it's definitely not oxygenated, right? So that's the fourth place where we can mix. The fifth place where we can mix is definitely going to be the aorta itself because ductus arteriosum, right? So right ventricle all the way here, also bringing mixed blood. So at all times, your embryo is exposed to about 80 to 90% oxygenated blood. So it doesn't drop below that. So even the venous blood here will always have approximately 80% of the oxygen. It is enough for the development. What are the changes after you're born? Well, after you're born, placenta is gone. So ligamentum teres hepatis, that's what?
The round ligament?
That's which structure became this?
Umbilical vein.
Umbilical vein. Umbilical vein after birth will become the ligamentum teres hepatis. There's also going to be ligamentum venosum right here, right? So don't forget, they didn't put it in the book, but you remember ligamentum venosum. After birth, what happens to foramen ovale? It closes, right? So you're going to see that it closes. So now the two circulations do not mix. After birth, ductus arteriosum will also close. It becomes ligamentum arteriosum. Maybe you remember, but it closes due to bradykinin. So this particular closure of the ligamentum arteriosum is mediated by the increased amount of bradykinin. Bradykinin increased due to inflation of the lungs. When the lungs stretch, when you inhale, bradykinin increases. And lastly, of course, your umbilical arteries will also be becoming ligaments, and you remember that they are within the medial umbilical ligaments. Okay, that's it. We are done.
And what about that's it?
We
What
didn't
about
do the
limbs?
limbs.
Oh shit, I thought we did the limbs. Sorry.
Okay.
Sorry. Let me find the limbs. Limbs. Okay, so very easy. It's a new topic. They only put it last year, so they don't even know what themselves are talking about, but it's a new topic. So basically, limbs together with your shoulder and pelvic girdles are going to be comprising the appendicular skeleton. At the end of the 4th week, no surprise, 4th week, we're going to see that there are going to be two protrusions, two limb buds. We have the forelimb and the hind limb, two kind of protrusions that we call forelimb and hind limb. Forelimb and hind limb will consist of the outer layer, which is the ectoderm, of course, and the inner layer is going to be mesenchyme. But where did this inner mesenchyme come from? It comes from the parietal mesoderm, because it makes sense. It's the extension of your body wall, basically that way. So you're going to see that definitely the mesenchyme in the limbs has arise from the parietal mesoderm. When the 6th week come in, you're going to see that the distal area of your forelimb, and when the 7th week comes in, going to be your hind limb, because hind limb is always 1 week later. So everything which is happening to the forelimb will happen to the hind limb, but always with 1 week difference. So when 6th week comes in, the distal portion of the forelimb dilates and creates a mitten-like structure. Do you see mittens, right? So mitten-like structure. The most distal part of the mitten has a name. So everything in the red line, this area has a name. This is known as the apical ectodermal ridge. So this part right here, the most distal part of the mitten, this is called apical ectodermal ridge. So guess which germ layer is proliferating there? Of course, the ectoderm, right? So ectoderm will be proliferating a lot in this area. So what happens next? This is your apical ectodermal ridge. Under the influence of the apical ectodermal ridge, the mesenchyme inside of this mitten will start to proliferate in the 5 digital arrays. So I repeat, the outer ectoderm that you have here forces the inner mesenchyme to proliferate a lot, but not like everywhere like a mitten. No, do you see? You can even see it here. It forces it to proliferate into like rays. These rays are called digital rays. So this is the protrusion of the mesenchyme this way. Why? Because of the apical ectodermal ridge. So it forces its protrusion like that. Simultaneously, when the digital rays appear, the rest of the apical ectodermal ridge starts to degenerate. So that part of the apical ectodermal ridge, which is located between the digital rays, degenerate. It undergoes apoptosis. The more it undergoes apoptosis, the more digital rays will grow. So the apoptosis of the apical ectodermal ridge between the digital rays definitely causes, how to say it, like appearance, proliferation of the digital rays. So this is another representation, another schematic representation of what we're talking about, right? So very important, you kind of form your normal digits at 56 days. You finish making your digits at 56 days. So your 5 fingers are right there. Yours truly does not have a complete separation. When I was born, I didn't have a complete separation. They actually separated for me, okay? So one of them is here. So between my first and second limb, this is skin right here. Okay, so this part is the skin. So it should have been here. So they were supposed to separate it all the way this way, but I don't have it, okay? So also fun fact, if your apical ectodermal ridge is still present, do you see? This is skin. Do you see? It's still there. So lots of people will have it actually, not a full separation. So I have it specifically in this area a lot, like a lot of skin. I'm not sure if you can see it there. But also one of the side effects of this is the lines. Do you see how many lines I have? All the extra skin right here. So this should have actually degenerated, but it didn't. So apical ectodermal ridge should be degenerating in a very nice manner. So your hand should not be this, how to say it, this loose. The skin should not be this loose. The skin should be super attached to the rest of your like muscles and etc. If it is a bit loose, then apical ectodermal ridge is definitely not doing its job. Super important thing. I cannot stress how important. That's what they want to hear right here. Now, we have said that forelimbs and hind limbs are approximately developing simultaneously, but everything which is happening to the forelimb typically happens to the hind limb approximately 1 week later. Okay, so not 1 to 2 days, approximately 1 week later. They have a 1 week difference in between them. During the 7th week of gestation, the limbs will be rotating in the opposite ends. This embryo is approximately 6 weeks old. How do I know? Because we still did not finish forming phase. This is the 7th week, right? So this is 6th week, this is 7th week. You're going to see that the limbs are still like a starfish. You basically are like this, okay? So notice how my limbs are, okay? So they're like that. So you're literally like a starfish. The upper limb will rotate 90 degrees laterally. So this upper limb rotates laterally 90 degrees. So you do something like this, okay? So you just rotate 90 degrees laterally. Because of your 90 degrees lateral rotation, the elbows end up facing posteriorly. Because of this rotation, elbows face posteriorly. The hind limbs rotate in the opposite direction. They rotate 90 degrees medially. And because they rotate 90 degrees medial, the knees end up facing anterior, right? So knees are going to be ending up facing anterior. Because of this, you see that flexors are located anteriorly in the upper limb, but in the lower limb, flexors are posteriorly because of this different rotation, right? The same goes for the extensors. The extensors are posterior on the upper limb, but anterior on the lower limb because of this different rotation. Is that clear? This rotation is important not only for that. As you know, these joints here are ball in a socket joint, right? So it's like a synovial joint, so it has to fully align there. Some babies are born with congenital dislocations. They are born with their shoulders and their like limbs being dislocated. So it's important to not only fully align your limbs, it's also important to fully form the joints to make sure that the heads of your bones definitely kind of fit into the sockets of the other bones. Because if it does not happen, you'll be born with dislocation. This is just blah, blah, blah. Okay, so they haven't been talking about it before. Basically, what all of this means is, you know that limbs are going to be endochondral ossification. So the mesenchyme in the upper lower limb will be condensing, differentiating to become chondroblasts. Chondroblasts will be creating cartilage, right? These chondrocytes will be trapped in that cartilage and etc. At the later stages, you're going to see that there's going to be kind of ossification of that area. So we will form some ossification centers like primary, secondary ossification centers. Inside of these ossification centers, you will find osteoblasts. These osteoblasts are going to come in and fully ossify that area, which is like you can talk about it in Histo 1 as well. So there's no new information on the slide. You know this, that mesenchyme, cartilage, and then bone. The same here, this is just the overview of ossification centers. So kind of refresh your memory on that. There are two ossification centers, right? So primary, secondary. What do we find between primary and secondary ossification centers?
Epiphyseal plate.
Epiphyseal growth plate. Because of this epiphyseal growth plate, you grow, right? So you're born a little tiny human, but then you end up being super tall. So that's because of the epiphyseal growth plate. The primary ossification centers appear by the 12th week. Make sure you know that. That's the overview of what we have just talked about. That's the endochondral ossification. So make sure you spend some time here. Okay, what is this? This is synovial membrane. You can honestly just cross it. They don't talk about it whatsoever. So like it was in the book, but they don't want to talk to you about it. And this is the last thing, which is important. Limbs are extensions of your body cavity, but they still have muscles. So these muscles have to come from the myotomes. So the question is, which myotomes? The forelimbs receive myotomes from the lower 5 cervical to the upper 2 thoracical myotomes. So that's why the innervation of the upper limb is the cephalobrachial cervical brachial plexus, right? So it's like it's partially with the brachial plexus there. The lower limbs will receive the myotomes from the lower 4 lumbar and the upper 2 sacral. So that's why the innervation is lumbar sacral. So these are the myotomes, dermatomes, right, and etc. So this is, for example, C5 myotome will go all the way this way. Molecular regulation is not important. I have given it this way, but so many people have gotten this topic last year. They said that they didn't ask this. So I taught it last year, but this year I'm not going to teach it because they said that they are not asking it. Okay, so for this limb topic, they have not a single person have been asked who have gotten this topic. Okay, so that's it. I have a couple of embryo 1 topics that are new. I will send them to you guys in the group. Yeah, so there's like teratogenicity, something like this. They are part of the embryo 1, but I will send them to you in the group. And that's it. So you remember